Hello there. This video will be divided into three parts as following. Normal features of chest X-ray, the abnormal features of chest X-ray, and the radiographic changes of heart failure.
Now we will talk about the normal features of chest X-ray.
Introduction. An X-ray radiograph is a non-invasive medical test that helps physicians diagnose and treat medical conditions. Imaging with X-rays involves exposing a part of the body to a small dose of ionizing radiation to produce pictures of the inside of the body. X-rays are the oldest and most frequently used form of medical imaging. Chest X-ray is also referred to as a chest radiograph, chest röntgenogram, or CXR. Depending on its density, each organ within the chest cavity absorbs varying degrees of radiation, producing different shadows on the film. Chest X-ray images are black and white, with only the brightness or darkness defining the various structures. For example, bones of the chest wall, such as ribs and vertebra, may absorb more of the radiation and thus appear whiter on the film. On the other hand, the lung tissue, which is mostly composed of air, will allow most of the radiation to pass through, developing the film to a darker appearance. The heart and the aorta will appear whitish, but usually less bright than the bones, which are more denser. Chest X-rays tests are ordered by physicians for a variety of reasons. Many clinical conditions can be evaluated by this simple radiology test. Some of the common conditions detected on a chest X-ray include pneumonia, enlarged heart, congestive heart failure, lung mass, rib fracture, fluid around the lung, which is called pleural effusion, and air around the lung, which is called pneumothorax.
Chest X-ray test procedure. To prepare for a chest X-ray, the patient is typically instructed to wear a gown and remove all metal-containing objects around the upper body, like necklaces, zippers, brass, buttons, jewelry, eyeglasses, etc., as these will interfere with the visualization of the tissues. No other specific preparation such as fasting is necessary for a routine chest X-ray. The patient is then asked by the technician to stand in front of a surface adjacent to the film that records the images. The front of the chest is closest to the surface. Another part of the machine that releases the radiation is then placed about 6 feet away, behind the patient. When the positioning is appropriate, normal standing position with arms on the sides, the technician may advise the patient to take a deep breath and hold it, and then takes the image by activating the device, similar to taking a regular photograph. The image is then captured on the film within a few seconds. The film can develop within a few minutes to be reviewed by the doctor. Usually, one image is done from back to front, referred to as posterior anterior or PA view, and as described above, a second image using a sideways view from side to side, which is called lateral, can be done as well. In situation where someone is unable to stand, too weak, disabled, or hospitalized, the image can be taken while laying down with the recording surface placed behind the back. Because the image is taken from the front to back in this scenario, it is called an anterior-posterior or AP view. A lateral film is generally not possible in these situations. This method can also be called a portable chest X-ray because the X-ray machine is wheeled into the patient in order to take the X-ray. Other chest images from different positions are sometimes ordered by the doctor for special situations.
Medical reasons for chest X-ray test. Doctors generally order chest X-ray test in conjunction with taking a medical history and performing a physical exam to confirm or exclude a suspected chest. Some of the common reasons to order a chest X-ray test are listed below. Cough, shortness of breath, chest pain, poor oxygenation, hypoxia, back pain, chest injury, fever. Certain abnormalities detected on the doctor's physical examination of the lung, heart, or chest wall, abnormal heart sound, abnormal lung sound, chest wall deformity, etc. A preoperative evaluation before an operation to screen for any previous lung disease. Follow-up of a previously abnormal chest X-ray test to confirm the proper placement of certain devices within the chest, such as a pacemaker, endotracheal, which is breathing tubes. When someone is placed on artificial breathing machine, catheters, enlarged vein of the chest, central lines, etc.
Normal chest X-ray test. As mentioned earlier, the image on chest X-ray film is in shades of black and white, similar to a negative of a regular photograph. The shadows on a chest X-ray test depend on the degree of absorbed radiation by the particular organ based on its composition. Bony structures absorb the most radiation and appear white on the film. Hollow structures containing mostly air, such as the lungs, normally appear dark. In a normal chest X-ray, the chest cavity is outlined on each side by the white bony structures that represent the ribs of the chest wall. On the top portion of the chest is the neck and the collarbones, the clavicles. On the bottom, the chest cavity is bordered by the diaphragm, under which is the abdominal cavity. On either side of the chest wall, the bones of the shoulders and arms are easily recognizable. Inside the chest cavity, the vertebral column can be seen down the middle of the chest, splitting it nearly in equal halves. On each side of the midline, the dark appearing lung fields are seen. The white shadow of the heart is in the middle of the field, atop of the diaphragm, and more to the left side. The trachea, the windpipe, the aorta, which is the main blood vessel exiting the heart, and the esophagus descend down the middle, overlapping the vertebral column.
Now, we'll talk about the abnormal features of a chest X-ray.
Abnormal chest X-ray test. Many abnormalities can be detected on a chest X-ray test. Some of the common abnormalities that can be seen on chest X-ray tests. For example, 1. We can detect the lung abnormalities by comparing the upper, middle, and lower lung zones on the left and right. Asymmetry of lung density is represented as either abnormal whiteness, increased density, or abnormal blackness, decreased density. Once you have spotted asymmetry, the next step is to decide which side is abnormal. If there is an area that is different from the surrounding lung, then this is likely to be the abnormal area. These are some of the common abnormal findings that can be seen on chest X-ray tests. Let's start. One of the common findings that can be seen using X-ray is lung cancer or any other lung masses. This slide shows two X-ray tests for two female patients. Picture A. The woman has breast cancer. Notice the white arrow as it shows a breast shadow on the right side, but does not have one on the left, because she has had a mastectomy for breast cancer. Such asymmetric density can cause an inexperienced film reader to mistakenly diagnose a lung abnormality. On the other hand, picture B. The patient suffers from lung cancer hiding in the apical region, often termed a Pancoast tumor. Look at the green arrow. These can be very difficult to be spotted by the untrained eye, and this area is an important trick area for radiologists when interpreting chest X-ray.
Which patient has punctured lung? Patient A has a small punctured lung, also known as pneumothorax, which can be difficult but very important diagnosis to make. Air is seen outside the lung with thin line representing the lung margin, known as the pleura, evident in the upper chest, green arrow. Patient B has fibrosis in the right lung apex, white arrow, which has led to reduction in lung volume with elevation of the diaphragm on that side. This was a cause of radiation-induced fibrosis. Pneumonia is airspace disease. Consolidation. The airspace are filled with bacteria or other microorganisms and pus. Other causes of airspace filling, not distinguishably radiographically, would be fluid, inflammatory cells, cancer, protein, alveolar proteinosis, and blood. Pulmonary hemorrhage. Pneumonia is not associated with volume loss. Pneumonia is caused by bacteria, virus, microplasma, and fungi. The X-ray findings of pneumonia are airspace opacity, lobar consolidation, or interstitial opicitis. There is usually considerable overlap. Aging pneumonia is a space-occupying lesion without volume loss. What differentiates it from a mass? Masses are generally more well-defined. Pneumonia may have an associated paranomic effusion.
Pleural effusion. Normal pleural space is lined by thin film of fluid. Visceral and parietal pleura are in opposition and they glide over each other during respiration. When excess fluid accumulates in pleural space, it's called pleural effusion. Imaging criteria are homogeneous density, density-independent portion, silhouette of upper limb of density, loss of silhouette. In the images below, note lack of identifiable left diaphragm before and visible diaphragm after clearance of fluid. Silhouette sign principle. Mediastinal shift. Cardiomegaly. The CTR is measured on a PA chest X-ray and is the ratio of maximal horizontal cardiac diameter to maximal horizontal thoracic diameter, inner edge of ribs over edge of pleura. A normal measurement should be less or equal 0.5. We can also detect dislocated shoulders, broken ribs or arm bones, and the broken vertebra or vertebral fractures. Look at the pictures below, from left to right. Dislocated shoulders, broken ribs, broken vertebra.
Now, the radiographic changes of heart failure.
Introduction. Congestive heart failure is the result of insufficient output because of cardiac failure, high resistance in the circulation, or fluid overload. Congestive heart failure starts with the left ventricle and then it will spread to the right one, and that's why we call it congestive heart failure. Firstly, it will start with left ventricle failure, and it is the most common, and it results in decreased cardiac output and increased pulmonary venous pressure. In the left ventricle failure, it will lead to dilation of pulmonary vessels, leakage of fluid into the interstitial and the pleural space, and finally into the alveoli, resulting in pulmonary edema. Then it will spread to the right ventricle failure, and is usually the result of long standing of the left ventricle failure or pulmonary diseases, and causes increased systemic venous pressure, resulting in edema in dependent tissue and abdominal viscera. In the illustration on the left, some of the features that can be seen on a chest film in a patient with congestive heart failure, just like increased heart size and increased intravascular pedicle. Increased pulmonary venous pressure is related to the pulmonary capillary wedge pressure and can be graded into stages, each with its own radiographic feature on the chest film. This grading system provides a logical sequence of signs in congestive heart failure. In daily clinical practice, however, some of these features are not seen in this sequence and sometimes may not be present at all. This can be seen in patients with chronic heart failure, mitral valve disease, and in chronic obstructive lung disease. Congestive heart failure. It's divided into 3 stages as shown in the figure on the left. For the first stage, there will be disruption and the pulmonary capillary wedge pressure will be from 13 to 18 mm mercury. But in stage 2, there will be interstitial edema and the pulmonary capillary wedge pressure it will be from 18 to 25 mm mercury. Finally, stage 3, there are an alveolar edema and the pulmonary capillary wedge pressure will be more than 25 mm mercury. And we will discuss each stage in details in the following slides.
Stage 1. Redistribution. In a normal chest film with the patient standing erect, the pulmonary vessels supplying the upper lung fields are smaller and fewer in number than those supplying the lung bases. The pulmonary vesicular bed has a significant reserve capacity and recruitment may open previously non-perfused vessels and causes distension of already perfused vessels. This results in a redistribution of pulmonary blood flow. First, there is equalization of blood flow and subsequently redistribution of flow from the lower to the upper lobes. The term redistribution applies to chest X-rays taken in full inspiration in the erect position. In daily clinical practice, many chest films are taken in a supine or semi-erect position, and the gravitational difference between the apex and the lung bases will be less. In the supine position, there will be equalization of blood flow, which may give the false impression of redistribution. In these cases, comparison with old films can be helpful. Artery to bronchus ratio. Normally, the vessels in the upper lobes are smaller than the accompanying bronchus with a ratio of 0.85. At the level of the helium, they are equal, and in the lower lobes, the arteries are larger with a ratio of 1.35. When there is redistribution of pulmonary blood flow, there will be an increased artery to bronchus ratio in the upper and middle lobes. This is best visible in the perhilar region. Now, on the left, a patient with cardiomegaly and redistribution. The upper lobe vessels have a diameter larger than 3 mm, while the normal is from 1 to 2 mm. Notice the increased artery to bronchus ratio at hilar level, shown by the arrows. Stage 2. Interstitial edema. Stage 2 of the congestive heart failure is characterized by fluid leakage into the interlobular and peribronchial interstatum as a result of the increased pressure in the capillaries. When fluid leaks into the peripheral interlobular septa, it is seen as curly P or septal lines. Curly P lines are seen as peripheral short 1 to 2 cm horizontal lines near the costophrenic angles. These lines run perpendicular to the pleura. Now, when fluid leaks into the peribronchovascular interstatum, it is seen as thickening of the bronchial walls, peribronchial cuffing, and as loss of definition of these vessels, perihilar haze. On the left, a patient with congestive heart failure. There is an increase in the caliber of the pulmonary vessels, and they have lost their definition because they are surrounded by edema. On the left, another patient with congestive heart failure. The lateral view nicely demonstrates the increased diameter of pulmonary vessels and the hazy contours. Notice also the septal lines and the accentuated interstatum. Furthermore, the fissura major is markedly thickened. Stage 3. Alveolar edema. This stage is characterized by continued fluid leakage into the interstatum, which cannot be compensated by lymphatic drainage. This eventually leads to fluid leakage in the alveoli, alveolar edema, and to the leakage into the pleural space, pleural effusion. The distribution of alveolar edema can be influenced by 1. Gravity, supine or erect position, and right or left decubitus position. 2. Obstructive lung disease, Example, fluid leakage into the less severe diseased areas of the lung. If you look to the left, you will see a patient who was admitted with severe dyspnea due to acute heart failure. The following signs indicate heart failure. 1. Alveolar edema with perihilar consolidation and air bronchograms shown by the yellow arrows. 2. Pleural fluid shown by the blue arrow. 3. Prominent azygous vein and increased with the vesicular pedicle shown by the red arrow, and an enlarged cardiac silhouette shown by the arrowheads. After treatment, we can still see an enlarged cardiac silhouette, pleural fluid, and redistribution of the pulmonary blood flow, but the edema has resolved, as seen in the left picture. On the left, another patient with alveolar edema at admission, which resolved after treatment. When you compare the images and go back and forth, you will notice the difference in vesicular pedicle width and the distribution of pulmonary flow. Regarding the first image, both on the chest X-ray and on the CT, the edema is gravity dependent and the differences in density can be measured. Regarding the second image, notice that even within each lobe there is a gravity-dependent difference in density. This is only seen when the consolidations are the result of a transudate, like in congestive heart failure. But this is not seen when the consolidations are a result of exudate due to infection, blood due to hemorrhage, or when there is a capillary leak, like in ARDS. Now, regarding the last image on the left, a patient who first had a chest film in a supine position. Notice the pulmonary edema, which is almost only seen in the right lung. A possible explanation for this phenomenon could be that the patient had been lying on his right side for a while before the X-ray was taken.
The cardiothoracic ratio is the ratio of a transverse diameter of the heart to the internal diameter of the chest at its widest point just above the dome of the diaphragm as measured on the posterior anterior chest film. An increased cardiac silhouette is almost always the result of cardiomegaly, but occasionally it's due to pericardial effusion or even fat deposition. The heart is considered too large when the cardiothoracic ratio is above 50% on anterior-posterior chest X-ray. A cardiothoracic ratio above 50% has a sensitivity of 50% of congenital heart failure and a specificity of 75 to 80%. An increase in left ventricle volume of at least 66% is necessarily before it is noticeable on the chest X-ray. Now, to sum those three paragraphs up, you need to know that the cardiothoracic ratio is the ratio of the transverse diameter of the heart to the internal diameter of the chest. Okay, and you need to know that an increase in cardiac silhouette is a sign of having an cardiomegaly. The heart is considered too large when its cardiothoracic ratio is above 50%. That's why when we have a cardiothoracic ratio that is above 50%, we might have a chance of 50% of having a congenital heart failure. On the left, we have a patient with congestive heart failure. As you can see, we have an increased heart size compared to the ELF film. Other signs that are visible on the congestive heart failure are redistribution of pulmonary flow, interstitial edema, and some pleural fluid. Pleural, guys. Yes, on the left, we have a patient who has recently underwent a valve transplant. As you can see in the chest X-ray, there is a large cardiac silhouette, which is an indication of cardiomegaly. And as the CT image, it demonstrates that we might have a pericardial effusion, which we should have be taken into account. On the other image, we have a patient with large cardiac silhouette on the chest X-ray due to pericardial effusion. As you can see, the pericardial effusion is demonstrated on the coronal cardiothoracic reconstruction.
Pleural effusion. Pleural effusion is bilateral in 70% of cases of CHF. When unilateral, it is slightly more often on the right side than on the left side. There has to be at least 175 milliliters of pleural fluid before it will be visible on a PA image as a meniscus in the costophrenic angle. on a lateral image effusion of greater than 75 milliliters can be visible. If pleural effusion is seen on a supine chest film, it means that there is at least 500 milliliters present. On the left images of a patient who has bilateral pleural effusions, notice that it is more evident on the lateral view. Pleural effusion is not always visible as a meniscus in the costophrenic angle. A subpulmonic effusion may follow the contour of the diaphragm, making it tricky to discern. In these cases, the only way to detect pleural effusion is when you notice that there is an increased distance between the stomach bubble and the lung. The stomach is normally located directly under the diaphragm, so on an erect PA radiograph, the stomach bubble should always appear in close proximity to the diaphragm and the lung. On the left images of a patient with signs of CHF, at first glance, you might get the impression that there is a high position of the diaphragm. However, when you notice the increased distance of the stomach air bubble to the lung base, you realize that there is a large amount of pleural fluid on both sides.
Vascular pedicle. The vascular pedicle is bordered on the right by the superior vena cava and on the left by the left subclavian artery origin. The vascular pedicle is an indicator of the intravascular volume. When the vascular pedicle width is less than 60 mm on posterior to anterior chest radiograph, it's a normal chest X-ray and we see it in 90% of them. But when the vascular pedicle width is more than 85 mm, it's pathologic and we see it in 80% of cases. Every 5 mm increase in diameter corresponds to 1 liter increase of intravascular fluid. An increase in width of the vascular pedicle is also accompanied by an increased width of the azygous vein. There are three principal varieties of pulmonary edema: cardiac, overhydration, and increased capillary permeability, and we call it ARDS. The vascular pedicle width can help us in differentiating these different forms of pulmonary edema. Firstly, we have normal vascular pedicle width. It's most common in capillary permeability or acute cardiac failure. Second one, widened vascular pedicle width, most common in overhydration, renal failure, and chronic cardiac failure. And finally, we have narrowed vascular pedicle width, most common in capillary permeability. Here on the left, we can see the first picture where it's a patient with increased width of vascular pedicle. But on the right, after 4 weeks, we can see that it go back to normal. In the picture below, there is a patient with ARDS. There is an alveolar edema in both lungs. And we can notice that the vascular pedicle width is normal and the vessels in the upper lobes are not dilated and the cardiac salute is not enlarged. The vascular pedicle width is best used as a measure to compare serial chest X-rays of the same patient, as there is a wide range of values for the vascular pedicle width. The vascular pedicle width may increase due to rotation to the right. And when we take the X-ray from anterior to posterior view, the vascular pedicle width will increase 20% compared to a posterior to anterior view. Here on the left, there is a patient with subtle signs of congestive heart failure on the initial chest X-ray. But in the second image, we can see that there is a slightly enlarged vascular pedicle, which become more obvious when you compare to the chest film after diuretic therapy.
Dilatation of azygous vein. Dilatation of the azygous vein is a sign of increased right atrial pressure and is usually seen when there is also an increase in the width of the vascular pedicle. The diameter of the azygous vein varies according to the positioning. In the standing position, a diameter less than 7 mm is most likely abnormal, and a diameter greater than 10 millimeters is definitely abnormal. In a supine patient, greater than 15 millimeters is abnormal. An increase of 3 millimeters in comparison to the previous films is suggestive of fluid overload. The difference of the azygos diameter on an inspiration film compared to an expiration film is only 1 millimeter. This means that the diameter of the azygos is a valuable tool whether or not there is good inspiration.
The right ventricular failure. Right ventricular failure is most commonly caused by long-standing left ventricular failure, which increases the pulmonary venous pressure and leads to pulmonary arterial hypertension, thus overloading the right ventricle. Other less common causes of right ventricle failure are severe lung disorder, multiple pulmonary emboli, right ventricular infarction, primary pulmonary hypertension, tricuspid regurgitation or stenosis, mitral stenosis, and pulmonary valve stenosis, radiographic signs of right ventricle failure, increased vascular pedicle width due to dilation of the superior vena cava, dilation of azygos vein, dilation of the right atrium. In many cases, there will be both signs, right ventricle and left ventricle failure. Sonographic signs of right ventricle failure, dilation of the inferior vena cava and hepatic veins, hepatomegaly, STSs. The indication of ultrasound examination in many of these patients is abnormal liver function test. It is therefore important to consider the possibility of right ventricular failure when a patient presents with liver enzymes abnormality. As you can see on the left, there is a dilation on the inferior vena cava and hepatic veins in a patient with a right ventricular failure. Under normal conditions, dynamic ultrasound will demonstrate changes in caliber of the inferior vena cava. These changes in caliber can be attributed to variations in blood flow in the inferior vena cava in accordance with the respiratory and cardiac cycles.